Hi everybody, welcome to Dr. Manny's YouTube Learnshops. This is part 2 of continuous renal replacement therapy, which again provides an overview. Now the learning objectives for this session are to overview CRRT, the requirements for CRRT, and continuous renal replacement therapy options. Okay, let's revisit. What's continuous renal replacement therapy? Well, in acute renal failure, there's an abrupt reduction in kidney function with an elevation in blood urea, creatinine, uric acid, waste products, and oliguria or anuria. Renal replacement therapy then is a treatment that removes waste products, salts, and excess water from the body. The renal replacement therapy can be intermittent renal replacement therapy, which is conventional, or it can be continuous. Continuous renal replacement therapy is therefore performed continuously without interruption, and it's typically venous, and it's considered to have advantages over intermittent renal replacement therapy, which include increased hemodynamic stability with a lower incidence of hypotension, improved survival, and a greater likelihood of renal recovery because the kidney isn't injured as it may be with hypotensive episodes in intermittent renal replacement therapy. When comprehending CRRT, we've got the patient. The patient typically has veno-venous access, which means blood comes out of a vein and returns into a vein. Unlike intermittent renal replacement therapy, which typically has a fistula or has access to an artery, pushes the blood out, and returns it to a vein. So, typically, the dirty blood, high in the waste product that you want to get rid of, or fluid, is pulled out of the body with a negative pressure. The pressure created by blood leaving the body is due to a negative pressure which can be recorded. The blood pump is what's responsible for pulling out the blood of the body and then pushing it through the filter back towards the body. The hemofilter is what cleans the blood. But before the blood gets to the filter, typically there may be anticoagulation that's provided, if it's been ordered, to prevent filter clotting. The pre-filter pressure is typically positive because the blood pump is pushing blood towards the filter. It's got to go through a very fine membrane, semi-permeable membrane, which is the filter. And in the process, it's the hemofilter that cleans the blood of whatever you want to get rid of. Either getting rid of water, getting rid of urea, getting rid of creatinine, getting rid of both. Then the blood returns to the patient's body. However, before it does, it goes through or bypasses an air detector. Because if there's any air in the blood, you don't want it going into the patient and causing an air embolism. So the blood is pushed back, and this creates a positive venous pressure. When the blood goes into the patient, it's essentially cleaned of whatever you wanted to get rid of. And it has to be returned via a positive pressure. It has to be pushed back into the body. This is the CRRT circuit. What's the rationale? Well, the rationale we essentially said. You want to get rid of something that the kidney can't get rid of. However, this can be used in respiratory failure due to diuretic refractory pulmonary edema, which can be cardiogenic, or it can be pulmonic. It can be because of nutritional requirements causing overload, so fluid can be taken off so the patient can get its nasogastric feed or its intravenous parenteral nutrition. Neurological anomalies which are refractory, such as cerebral edema, the diuretics aren't working. Mannitol's not working, furosemide's not working, hypertonic solutions aren't working, so CRRT can be a therapy that can be considered. Heart failure. Heart's not responding to the vasopressor, refractory. So the patient can have systemic and pulmonary edema. So CRRT can be something that can be employed. Renal failure, well, the kidneys aren't responding to the diuretics. Rationale for CRRT, in a nutshell. Commencement criteria, as we mentioned previously, oliguria and urea. Azotemia, high nitrogen load. Uremic complications, severe hyperkalemia, severe dysnatremia. Refractory pulmonary edema, which we said can be cardiogenic or pulmonic. Removal of cytokines in relation to inflammatory responses. Refractory metabolic acidosis, hyperpyrexia. Removal of pathogenic proteins. Imminent or ongoing massive blood transfusions. Removal of septic mediators. And a SARCA, multi-organ failure, maybe a drug overdose with water-soluble toxins. Okay, when we look at requirements for CRRT, we have to consider vascular access, and typically a central vein is preferred, and the access has to be effective, viable, because again you want it to be efficient and function without interruption. Because remember, when you're sucking out blood negative pressure, the vein can collapse if it's a small vein. So a central vein or right atrial access is preferable. Typically, a dual lumen temporary hemodialysis catheter are the catheters of choice. They have a red port, which is the port that is typically connected to pulling out the blood from the body, and it's typically smaller. In this case, 1.3 cc is the lumen volume. Blood returning to the body is usually the blue port, and this is typically, on this catheter here, 1.4 cc. Catheters can also be tunnelled if the therapy is going to be utilised for a longer period of time. There are typically three main access sites for the placement of central venous catheters that are being utilised for continuous renal replacement therapy: subclavian, internal jugular, and femoral. Subclavian is the preferred site, lower incidence of infection, and close to the heart, so therefore the vein typically doesn't collapse. Good filling. Venous vascular access. These are access devices, and there's no preference. Whoever the physician is, they will have their preference. So no recommendation is being made here. Typical sizes, however, for vascular access in the vein in a newborn, 6.5 French, child 8.5 French, adult greater than 11 French. And note that 90% of the troubleshooting problems occur from the vascular access devices, not the machine. So the right choice of device is really important, and this is physician preference. What are some of the anticoagulation options when we use continuous renal replacement therapy? First of all, the patient is considered whether they're contraindicated for regional citrate anticoagulation, which is the most popular these days because it has a lower risk and it promotes anticoagulation that is effective. However, if it's not being considered, then you've got other choices such as heparin, or you may have other choices that basically say we don't want any. It depends on the physician and their preference and the patient's condition. So there are lots and lots of protocols, and it depends on your healthcare organisation. If we consider citrate, regional, it's typically in the replacement solution and it follows hospital guidelines. So regional citrate anticoagulation is the infusion of citrate into the blood circuit during CRRT to remove or chelate ionised calcium. forming calcium citrate complexes, therefore preventing the coagulation of blood. There are numerous protocols that can be followed. It depends on your hospital guidelines. Then you've got heparin. And heparin by convention can also be given regionally. And traditionally it's been the most common anticoagulant used for CRRT. However, there is increasing evidence that suggests that heparin is less effective than citrate in prolonging the circuit life, and there's a risk of hemorrhage. There are numerous protocols as well which can be used, and some of them implement protamine in the return line to neutralise any heparin that might go into the patient. The purpose of the heparin in this circuit that you're looking at is to promote anticoagulation in the filter and the tubing pre and post filter. However, protamine neutralises the heparin before the blood returns to the patient via the blue or venous line, thereby decreasing the risk of infection. No, not infection, hemorrhage. Then we have prostacyclin. And prostacyclin also has to follow hospital guidelines. And it's a platelet inhibitor that can be safely used as an efficient anticoagulant in CRRT. And it can be combined with heparin, and if it does, it induces a heparin sparing effect, which means you don't have to use as much, which can reduce the dosage and side effects of heparin. Prostacyclin. So what are the objectives of anticoagulation for CRRT? Well, the objectives basically are about safety. However, it is to maintain the patency of the extracorporeal circuit, which again is anything that is outside the patient. So the filter, the tubing, the access device, to prevent clotting. It's to minimise potential complications of anticoagulation, which could involve hemorrhaging. And we do this by monitoring the ACT, the activated clotting time, and the APTT, which is the partial thromboplastin time or the activated partial thromboplastin time, which can be done at the bedside. What are some of the therapy options which we'll be looking at in more detail in other parts of this Learnshop? We have SCUF, slow continuous ultrafiltration, CWVH, continuous venous hemofiltration, CWVHD, continuous venous hemodialysis, and CWVHDF, continuous venous hemodiafiltration. With slow continuous ultrafiltration, SCUF, this is the removal of excessive fluid from the blood, and it's by ultrafiltration. There's no dialysate used, there's no replacement fluid used, and the intended use is essentially for diuretic fluid retention, which occurs in pulmonary edema, which can be cardiogenic, heart failure, or pulmonic, which can occur in situations like acute respiratory distress syndrome. The treatment parameters are variable, which we'll be discussing in detail when we look at specific therapies related to specific components in other Learnshops. So ultrafiltration is really plasma water removal, and this occurs when solvent, the fluid, and the solutes or particles in the solvent are pushed or pulled across a semipermeable membrane due to a driving pressure, which can be positive or negative. Continuous veno-venous hemofiltration, CVVH, this removes solutes by convection and ultrafiltration. And typically there is the use of a replacement fluid which now dilutes the blood. The intended use is for acute kidney injuries, life-threatening homeostasis problems where you've got electrolyte imbalances, acid-base disturbances, which can be profound, or removal of septic mediators such as cytokines, and again in pulmonary edema. In CVVH, or you can refer to it as CVVHF, continuous veno-venous hemofiltration, there's plasma water exchange. And this is the simultaneous removal of plasma water by ultrafiltration and a replacement fluid that has a buffered electrolyte solution, and it doesn't have any of the waste products that you want to remove. And this exchange process achieves a reduction in the concentration of toxins. In a sense, it purifies the blood. It cleans it. In continuous veno-venous hemodialysis, CVVHD, this is where you remove solutes that you don't want by diffusion and ultrafiltration, and you use a dialysate solution. And the intended use, again, is similar to the other situations: acute kidney injury, uremia, life-threatening homeostatic problems such as electrolyte imbalances, which can occur in hyperkalemia, for example, acid-base imbalances, metabolic acidosis, and removal of septic mediators such as cytokines. In continuous venous hemodialysis, there's a solute removal. And this is where you remove solutes in the blood by introducing a clean dialysate solution. Clean meaning that it doesn't have any of the products that you want to remove in it, and therefore they'll move from a high to a low concentration by diffusion. And it pulls metabolites like urea from the blood into the dialysate, reducing the unwanted plasma metabolites, reducing the uremic effects. Then you've got continuous veno-venous hemodiafiltration, a combination of everything. This removes solutes and fluid by diffusion, convection and ultrafiltration with the use of a dialysate and a replacement solution. The intended use, again, acute kidney injury, uremia, homeostatic life-threatening situations, and removal of septic mediators, and acute pulmonary edema, which can be cardiogenic or pulmonic. In CVVHDF, plasma water is removed by hemofiltration, solute removes by hemodialysis. So therefore, CVVHDF combines hemodialysis, which has the process of diffusion, and hemofiltration, which utilises convection or solute drag. And therefore both remove unwanted solutes and plasma water. So let's review. Name 3 regional anticoagulant options for CRRT. They are citrate, or regional citrate anticoagulation, heparin, which is regional heparinization, and regional prostacyclin. All will have specific hospital guidelines and physician preferences which must be followed. Name 4 therapy options that were reviewed for CRRT. The therapy options are SCUF, slow continuous ultrafiltration, CVVH or CVVHF, continuous veno-venous hemofiltration, CVVHD, continuous veno-venous hemodialysis, and CVVHDF, continuous veno-venous hemodiafiltration. Have an attempt at filling in the missing sections in this CRRT circuit. Follow it through from the patient 1, 2, 3. The missing components are the pre-filter pressure, the dialysate, the hemofilter, and the clean blood returning to the patient's body. 1. Dirty blood is pulled out by a negative pressure, is then pushed by the blood pump towards the filter to push it through to be cleaned. It continues to push the blood towards return line to the patient. It's clean. 1. Dirty blood pulled out of the body. 2. Cleaned in the hemofilter and dialyzer and returned to the patient, cleaned of whatever was wanted to be removed. So in summary, CRRT is a strategy for acute kidney injury in critically ill patients, as it removes not only waste products but other molecules such as cytokines, which are targeted for removal, especially in septic patients. The modalities that were reviewed included slow continuous ultrafiltration SCUF, continuous veno-venous hemofiltration or CVVH, continuous veno-venous hemodialysis CWVHD, and continuous veno-venous hemodiafiltration CWVHDF. CVVH can also be referred to as CHF, continuous hemofiltration. CWVHD can also be referred to as continuous hemodialysis, and CWVHDF can also be referred to as continuous hemodiafiltration. The Learnshops Part 3 and 4 will review the Prismaflex and multifiltrate hemofilters and dialyzers, which will provide some sort of practical user-friendly information for you. I've chosen these because these are two hemofilters and dialyzers that I've used in my career, and I found them to be very user-friendly. I'm not promoting them as far as financial gains. I just like them both. Thanks again. Now that you've reviewed Learnshop Part 2, move on to Part 3. And as I've said previously, if you found this to be of any benefit, recommend it, subscribe to your colleagues. See you in the next Learnshop.